Cancer is a neoplastic disease process that involves abnormal cell growth and differentiation. The exact cause of cancer is unknown, but the triggering factors that are thought to create this abnormal cell growth are viruses, physical and chemical agents, hormones, genetics, and diet. Cancer cells can invade surrounding tissues, and it can also spread to other areas of the body through the lymph and blood vessels, and that's called metastases. Cancers can arise from almost any tissue in the body. Carcinomas come from epithelial tissue. Adenocarcinomas arise from glandular organs. Sarcomas arise from mesenchymal tissue. Leukemias are malignancies of the blood-forming cells. Lymphomas arise from lymph tissue, and multiple myelomas arise from plasma cells, and they affect the bone. Screening and early diagnosis is the most important thing that we can do for our patients, and educate them to do so. Risk factors. Age. The highest incidence of cancer occurs in older adults. Older women most commonly develop colorectal, breast, lung, pancreatic, and ovarian cancers. And older men most commonly develop lung, colorectal, prostate, pancreatic, and gastric. When it comes to race, Caucasian women over the age of 40 are more likely to develop breast cancer than African American, American Indian, or Hispanic women. However, the death rate for the other groups is higher than that of the Caucasian group, and that's thought to be about socioeconomic and health care coverage and early intervention. Caucasian men are increased risk for testicular cancer, where African American men have an increased risk for prostate cancer. Other risk factors include a genetic predisposition, exposure to chemicals, viruses, alcohol, and of course tobacco. That's the biggie. Tobacco is the big one. Exposure to certain kinds of viruses and bacteria. A liver cancer can develop many years after an infection of hepatitis B or C, and we know that can sit dormant for a long period of time. Infection with human T-cell leukemia virus increases the risk of lymphoma and leukemia. And this is indigenous to certain areas in the world like Africa and Melanesia. Infection with an Epstein-Barr virus has been linked to increased risk of lymphoma, and we also talked about that as linked to other immune suppressive diseases. The human papillomavirus, HPV infection, is the main cause of cervical cancer. Unfortunately, we have a vaccination for that now, and we want to encourage our young prepubescent girls to get that immunization. HIV increases the risk of lymphoma and Kaposi sarcoma, and H. pylori or Helicobacter pylori may increase the risk of stomach cancer and lymphoma of the stomach lining. Other risk factors are a diet high in fat and red meat and low in fiber. The sun plays a role, ultraviolet light, radiation exposure, lifestyle, sexual lifestyles, multiple sex partners or STDs, and then also lifestyle of poverty, obesity, and a chronic GERD increase the risk for different types of cancer. So what are we looking for? What are the signs and symptoms? Let's check that out on the next page. Okay, so this one has the risk factors I just went over, but now we're going to talk about signs and symptoms. Clinical findings depend on the type and location of the cancer, but there's 7 warning signs, and it spells out caution. It's a great way to remember this. C is for change in bowel or bladder habits. A would be a sore that doesn't heal. U would be unusual bleeding or discharge anywhere. Thickening is T, thickening or a lump in the breast or elsewhere. Indigestion or difficulty swallowing is the I. O is an obvious change in warts or moles, and N is a nagging cough or hoarseness. Other signs and symptoms include weight loss, fatigue, weakness, pain, and usually you don't see pain until later in the disease process, and nausea and anorexia. Our diagnostic procedures include genetic testing, where mutations in these genes can predispose a woman to having a high risk of breast cancer. And the actual genes they're looking for, which you don't need to memorize, of course, BRCA1 and the BRCA2. We can look at tissue biopsy, and we get a definitive diagnosis from that with abnormal cancer cells that's viewed under the microscope. A CBC and differential is used for screening for leukemias. Chest x-rays, CTs, MRIs, PET scans, SPECT scans, they all are used to visualize tumors, metastases, or progression of cancer. Tumor marker assays, such as the CEA, which is the carcinoembryonic antigen, and the cancer antigen 125. There's the PSA, and that's the prostate-specific antigen. We've heard of that. The human chronic gonadotropin, the alpha fetoprotein. Is here that used in prepartum during pregnancy, so check for that alpha fetoprotein. And they're blood tests that screen for cancers of the colon, pancreas, liver, prostate, uterus, and ovaries. And elevated values are suggestive of cancer. And don't confuse that with the alpha fetoprotein elevation that they look for in pregnancy. That's different. They're looking for this is for cancer in someone who's not pregnant. Shouldn't even put that in there. Anyway, we need to go on with staging. And these, the staging, this is important for you to know. You can go and look in IGGI. This is explained quite well. And that's the tumor node metastases system, and it's used to stage cancer. And the T stands for tumor, the N stands for node, and the M stands for metastases. And underneath those things, or beside them, like a TX, X means it's unable to evaluate the primary tumor. If you have an NX, that means they're unable to evaluate the regional lymph nodes. And if you have an MX, they're unable to evaluate distant metastases. A T0 means there's no evidence of a primary tumor. An N0 would mean there's no evidence of regional node involvement. And then an M0 means there's no evidence of distant metastases. The TIS, it just stands for tumor in situ. And then there's the 1, 2, 3, 4 system. And so a T1 it tells about this, would be the size and the extent of the tumor. An N1 would be a number of nodes that are involved, or the extent of the spread. So you can have N2, that would be 3 nodes, and 3 nodes, or N2 would be 2 nodes, N3 would be 3 nodes. And then the M1, if it says M1, then there is a presence of distant metastases. So review that in your text. The complications that we would see on in someone who has cancer, these are classified as oncologic emergencies. First one is the syndrome of inappropriate antidiuretic hormone, which is SIADH. And that occurs when there's excessive levels of antidiuretic hormones that are being produced. And it's because the antidiuretic hormones help the kidneys and the body conserve the correct amount of water. SIADH causes the body to retain water. And then we see a dilution of electrolytes such as sodium in the blood. And this is most commonly seen in lung and brain cancers. So as nurses, we want to make sure that we're looking for hyponatremia and a low serum osmolality. Often it's treated by diuresing with Lasix. We use an IV solution of normal saline, or a hypertonic saline is prescribed for severe hyponatremia. So it's dilutional typically. We're going to closely look at the vital signs, and the serum sodium, as the Lasix will promote a sodium excretion, and the hypertonic saline can cause fluid overload. So we have to watch these very closely. Another emergency would be hyperkalemia, And that's a common complication of leukemia, breast, lung, head, neck cancers. Also, complication of lymphomas, multiple myelomas, and bony metastases of any type of cancer. Symptoms we see with these individuals with hypercalcemia are an anorexia, nausea, vomiting. They have on their EKG a shortened QT interval, so that's a little thing to think about. Kidney stones, bone pain, and they may have a change in their mental status. As nurses, we will be giving normal saline, Lasix, phosphates as prescribed, and pimidronate also can be used to help with the high calcium. Superior vena cava syndrome is another complication or emergency situation. It results because there's an obstruction, and it's probably because of metastases of either breast or lung cancer. Anyways, it obstructs the venous return and the engorgement of the vessels of the head and upper body, and so then you see this periorbital and facial edema, erythema of the upper body, dyspnea, and epistaxis or nosebleed. We want to make sure that we sit the patient up in high Fowlers to facilitate lung expansion, and usually they'll try and reduce the tumor by high doses of radiation, and that provides a temporary or a palliative relief. Disseminated intravascular coagulation, or DIC, is a coagulation complication secondary to leukemia or adenocarcinomas. We want to watch our patients for bleeding and apply pressure as needed, of course. And we're going to be prepared to administer blood clotting factors that have been lost through the bleeding and may need to be replaced with plasma. Heparin is also used to slow the cascade of events that makes the body overuse the body's clotting factors. Treatments. I used to say there was just 3 things that you could do about cancer. You can either poison it, burn it, or cut it out. Well, there's a couple more. Chemotherapy is the poisoning, radiation is the burning, cutting it out is surgery, but we also have hormonal therapy and immunotherapy now. So treatment options focus on removing or destroying the cancer cells and prevent continued abnormal cell growth and differentiation, which is what the problem is. So like I said before, we want to be knowledgeable about chemo, radiation, hormonal therapy, immunotherapy, and of course surgical intervention. Many cancers are curable if they are diagnosed early. So once again, we want to impress upon our patients early diagnosis. Let's talk about chemotherapy first. It involves the administration of systemic or local cytotoxic medications that can damage the cell's DNA or destroy rapidly dividing cells. They're usually selected in relation to their effect on various stages of cell division. And then also there's combinations of anti-cancer medications used to enhance destruction of cancer cells. So often a cocktail of chemotherapeutic agents are prescribed. They have many adverse effects. They're related to the unintentional harm done to the normal proliferating cells, such as those in the GI tract, hair follicles, and bone marrow. And those are typically the ones that are affected the most by the chemotherapy, because it doesn't know just to go to the cancer cells that are rapidly proliferating, but it attacks all cells that rapidly proliferate. It can be administered. Patients can come into the hospital and have it. We don't see that as much anymore. We see them more in there when there's complications. Often they're going to an outpatient facility, often the oncologist's office, a clinic, and sometimes they even get them at home. And depending on the agent, it can be given orally, parental, IV, intercavitary, or interthecal. And all nurses who actually provide chemo have to have a special training and certification to administer these agents. They are often given through central ports, typically implanted ports, because they're intended to be given over a long-term basis, and we talked about that. in simulation lab when we go over central venous catheters. So usually the port has a small reservoir. It has that thick septum that is penetrated by a needle, and it's used there for long-term use, like I said. Follow your hospital's policy and guidelines for accessing the port. And if you have any extravasation of the agents, they're vesicant, and they often require special and immediate attention so that there's no tissue damage or necrosis. And there's neutralizing solutions that are given depending on the vesicant that's used. So if you notice that you're giving a chemotherapeutic agent and it starts to infiltrate, that you need to act on that immediately. So, like I said, chemotherapy can be used to cure disease. It helps control progression of the disease, or it can be palliative if the patient is terminal. It's most commonly used treatment for cancer, but can also be used for other disorders. As we've talked about in immunosuppressant disease, you'll see methotrexates used quite often. So we want to make sure that our patients are very much educated about what they're getting, and that they understand the management of the adverse effects, and that is our primary focus. So those complications that can occur is immunosuppression to the bone marrow. So we want to make sure that we're paying attention to their WBC count, their temperature. We want to report any fever immediately. Cultures can be done prior to giving any antimicrobials. If their WBCs drop below 1,000, we want to make sure that we put them on neutropenic precautions, and they have to remain in that room unless they have to leave for a diagnostic procedure, and if they do, they must have a mask on. We want to protect them from sources of infection, so no plants in the room. All equipment needs to be changed daily. We want to restrict who can go in and out of the room. Very, very strict hand hygiene. Avoid invasive procedures on someone who is neutropenic. They're designate equipment for that patient's room only. And anyways, I'll review neutropenic precautions in your textbook. We're also going to need to educate their patients to avoid crowds while they're on chemotherapy. They need to avoid eating fresh fruits and vegetables that contain a bacteria. Avoid yard work, gardening, changing the litter box. Avoid drinking any fluids that have been sitting around at room temperature for greater than 1 hour, because bacteria grows in water, so don't drink that water that's been sitting at the bedside for 2 days. Wash their toothbrush in the dishwasher daily, or rinse it in a bleach solution, and report any fevers. What else have I got? Complications. Nausea and vomiting and anorexia. That's another one. There's a typo there. Okay. We know many medications used for chemo cause nausea, vomiting, and then they can have an altered taste in the mouth where they become anorexic because their mouth tastes weird. So serotonin blockers like Zofran have been found to be very effective, along with some corticosteroids, phenothiazines, and antihistamines. We're really good at this now. We should not let your patients shouldn't experience nausea and vomiting from chemotherapeutic agents. We need to be on top of this as nurses. We want to give the antiemetics appropriately, timing them prior to the treatment. And they need to be given for several days afterwards as well. We can also teach visual imagery, relaxation techniques. They help with antiemetic use. We want to make sure that our patients are adequately nourished, so we might be doing calorie counts on them, give them liquid supplements, protein powders. Megace is often used. Megestrol, it enhances their appetite. We've given that a few times over this semester. And then often perform mouth care because that prior to having meals, because they may have that altered taste in their mouth. We want to talk to our patients about an antiemetic, schedule them schedule them prior to meals, and how important it is that they keep eating, and that we treat their nausea, vomiting, and we want them to eat high protein, high calorie, nutrient dense foods. We want to avoid empty calorie food. If they have that metallic taste in their mouth, hard candy helps somewhat. We avoid red meats for some reason. The red meats, it enhances that metallic taste. Another complication is alopecia. This is huge one. It's hair loss. It's very much an effect on body image. See it with chemo medications, and that's because it interferes with the life cycle of the rapidly proliferating cells, and that's hair growth. So we want to talk to the client about self-image and hats, turbans, wigs. How do we get to deal with the hair loss? There's some wonderful places out there and supportive stores and groups for women primarily, but men do go through this as well. And you want to make sure that you tell them that it's temporary and their hair is going to return after the chemo is discontinued. They may want to cut their hair short before treatment to decrease the weight on the hair follicle. And then some choose to actually, once the hair starts to fall out, to shave their head, because it really does come out in clumps, and there's just such a loss so quickly. After the hair loss, they need to protect their scalp from the sun, and they may need to use kind of an ointment to decrease the itching. Mucocystis is also referred to as stomatitis. It's an inflammation of the tissues of the mouth, gums, roof of the mouth, tongue, inside of the lips and cheeks. This is a miserable situation. We want to look at our patients' mouths several times a day and inquire about if they have any oral lesions in their mouth. Document the location and size of them. Do not use those glycerin-based swabs or mouthwash that just dries them out and hurts. We have topical anesthetics that they can use prior to meals, and then salty, acidic, or spicy foods probably will hurt more. We want to make sure we do mouth care before and after each meal to help them keep getting their nutrition in and to make it easier for them. There are some solutions out there, like a half base saline, half peroxide twice a day. There's other mouthwashes available for individuals who have mucocystis. Soft foods is on the diet: mashed potatoes, scrambled eggs, milkshakes. Cold things often feel good: frozen yogurt, that type of thing. Last complication I'm going to talk about is anemia and thrombocytopenia. Anemia being a decreased number of circulating red blood cells, and thrombocytopenia is a decreased number of circulating platelets. And that's secondary to the bone marrow suppression. And once again, that suppression is because the chemo suppresses anything that has rapid proliferation. We want to monitor our patients for fatigue, pallor, dizziness, shortness of breath. We want to cluster their care, give them rest periods. Give them any erythropoietic medications like erythropoietin alpha, that's Epogen. Ferrosol, parasulfate might be also prescribed. We're going to watch their hemoglobin in response to these medications. They may actually even get a transfusion. Now with thrombocytopenia, we're going to look for petechiae, ecchymosis, bleeding of the gums, nosebleed, any frank blood anywhere. So blood in the urine, stool. If they're vomiting, we're going to look for any blood in the vomit. Bleeding precautions must be instituted, so we're going to minimal IV access, injections. We're going to need to apply pressure after blood draws. We want them to avoid any type of trauma, as if trauma is anybody goes out looking for it. I don't know why I'd say that. Anyway, administer things like thrombopoietic medications like interleukin 11, and that might decrease the need for a platelet transfusion and lessen the risk of bleeding. I haven't seen it offered that often. So we're going to make sure we talk to our clients about our risks. It's much like someone who's on an anticoagulant. Electric razor use instead of a blade, soft toothbrushes, no flossing, blow your nose only when necessary, wear shoes when ambulating. You don't want to get any hurt feet, and they need to avoid using NSAIDs as well because of the increased bleeding risk. Radiation therapy involves the use of ionizing radiation to target tissues and destroy cells. The side effects of radiation include changes in the skin, hair loss, and debilitating fatigue. It can be administered internally with an implant or externally. And the radiation therapy can be curative. It's also used in conjunction with other treatments, and hopefully it increases the patient's survival rate and time. It can be given preoperatively to decrease the size of a tumor or to treat metastatic tumors in clients who are in terminal stages, so it can be used palliatively as well. Internal radiation is brachytherapy, and it's used as internal. Typically, it's seeds or little beads that's placed into the target tissue, and it's done through an orifice, so it can be put in through the vagina, in a body cavity like the abdomen. It can be delivered IV, such as a radionuclide iodine, that's then taken up by the thyroid. And then they can also seed prostate, and that's done through the urethra. Patients who have some type of the internal radiation need to be in a private room. There should be signs put up warning of the radiation. There's a radiation source. Health personnel that go in and out of the room should have a film badge, like you see the rad techs using, just to record the amounts of radiation exposure. If there's visitors, they need to limit their time, 30 minutes usually, maintain a distance of 6 feet. No pregnant women, no one under 16. They can stay. If they go home with the seeds in, like if Grandpa goes home with prostate seeds in, he just shouldn't be bouncing the baby on his knee. They can be in the same room once they're home. In the hospital, there should be a lead container that's kept in the patient's room in case there is, for some reason, one of the radiation seeds or bead, whatever, spontaneously falls out. We have to have tongs available for placing that radioactive material into a lead container. And you want to make sure that everybody who comes in, who's caring for that individual, understands, if they have to, how many times they have to flush the toilet, or etc. for someone who has radiation implanted. And of course, we need to instruct the patient about that as well. With external radiation, it's also called teletherapy, and that's delivered over a course of several weeks. Research shows that there are better results with small doses over a long period of time. So when we prepare our patients, the patient's skin over the targeted area is marked with what they call a tattoo. And it's just marker. It's not really tattooed on them. And it guides the positioning of the external radiation source. We want to make sure that our patients understand that not to wash off those markings. Let's see what else we want to talk to them about. Diet. Minimal red meat, because it can cause the radiation causes dysgeusia, Dysgeusia is how you spell it, and that makes foods such as red meat unpalatable. We want to help the patients who have that extreme fatigue to cluster their care, energy saving measures, teach them about things like that. And the symptoms related to the body that we're going to treat the symptoms related to the area of the body that's being treated. So if they're getting radiation to their mouth, they're probably going to end up with mucocystis, xerostomia, dry mouth. If it's on their neck, they might have difficulty swallowing. If they're having radiation towards their abdomen, they might have gastroenteritis. So we want to make sure that we talk to them about the common side effect of fatigue, that they care for their skin very carefully with mild soap and water, dry the area, don't remove the tattoo, I already said that, no powders, ointments, lotions, that kind of thing. Soft clothing over the irradiated area and to avoid anything tight or constricting. To protect that irradiated skin from heat source or from sunlight. It can be very damaging. And sometimes they'll prescribe a special ointment, but that has to be doctor's prescription. Make sure they're not using any home remedies on that skin. Finally, the last two, which are hormonal therapy and immunotherapy or biologic response modifiers. Hormonal therapy is effective against tumors that are supported or suppressed by hormones. And hormone agonists, such as gonadotropin-releasing hormone agonists, they're effective against tumors that require particular hormone support. These individuals need you to monitor their cardiac status and their blood pressure. They're at risk for pulmonary edema. You want to talk to our patients about the male clients specifically. It could have an impact on their sexual functioning. There might be some feminizing effects from the hormone therapy where they'll get gynecomastia, hot flashes, that type of thing. And they often need to be supported with calcium and vitamin D. The hormone antagonists are also effective against tumors that require particular hormonal support, and they use anti-estrogen hormone in a client with an estrogen-dependent cancer can actually suppress the growth of that type of cancer. And that's the same for an anti-testosterone hormones as well. So with those ones, we're going to watch our patients' liver enzymes, the CBC. We're going to warn them also again about the feminizing effects of the hormone therapy. Estrogen antagonists like tamoxifen, that's the one that we hear about the most. They're used for cancers that express the estrogen receptor. And we want to monitor their CBC, clotting times, their lipid, calcium, cholesterol levels, liver functions. Look for neurologic or cardiovascular functioning and note if there's any changes. We want our patients to tell us if they have any side effects such as that, or nausea, vomiting, hot flashes, weight gain, vaginal bleeding. They have an increase for thrombosis with this drug. They need a yearly gynecologic exam, and they may also need to be taking the vitamin D and the calcium as supplements for that. Immunotherapy or biologic response modifiers alter the client's biologic response to cancerous tumors. Interleukins and interferons are the two primary cytokines used in immunotherapy. And cytokines are the primary biologic response modifiers that we use currently, and they work to enhance the immune system. They help the client's immune system recognize cancer cells and use the body's own natural defenses to destroy them. So with the interleukins, we're going to see flu-like symptoms. And with the interferons, we can see peripheral neuropathy or orthostatic hypotension.